Hi everyone, I'm going to wrap up the content for psychology today. This is our last chapter, chapter 14, regarding treatment and therapies to treat mental illness and disorders. So I'm just going to go through a few of the slides. I also posted some content about CBD and the DBT as well, and how they compare and contrast, which is one of the questions on your final quiz, so that should help, that information. I'm not sure if this will take me 15 minutes or 30, but no more than 2 videos. So we'll see how we do as we go through some of the content. So when you open the chapter 14, it begins with a little bit of a history lesson in terms of how mental illness has been treated historically. So, back 40 years ago, 50 years ago, sort of like, 40s, 50s, 60s, most people, if they had mental illness, especially any of the more severe ones, were put in asylums, institutions, psychiatric wards, what was often known as the NS, which was I can't remember the exact term, but I think it was the Nova Scotia Psychiatric Hospital or something like that. In New Brunswick, there was a huge one in St. John called Centre Care. And they were asylums. They were places that, before ethical and professional practice, before good research where we understood more about mental illness, they were places that people lived, yes, but also places where some pretty awful things happened. A lot of treatments that today would never be acceptable. Shock treatments, surgeries, lobotomies where they would cut off a piece of the frontal lobe, and heavy sedation, straitjackets, isolation, that kind of stuff, mostly because of a lack of awareness and understanding. So then when deinstitutionalization happened, the intent was to bring people out of these facilities and get them back into community, back with families and homes, and reduce sort of the segregation. Like, we often segregated anybody who was different back then. People with mental illness went into institutions and asylums. There was a deaf school and the blind school. It wasn't integrated and inclusive the way we know society today. So those were the times, right? But anyway, through deinstitutionalization, people were encouraged to keep their children and keep loved ones at home. Even things like Down syndrome, which was, is a mental retardation. It's a disorder, a chromosomal disorder. When that would happen back in the 50s and 60s and 70s even, mothers and fathers would be told that that child was a mongrel and to not keep them. And so they might go to a place like Sunset or to one of those hospitals. Well, that wouldn't happen today. Today, those children are raised in home and loved like all children are supposed to be. Treatments are done, of course, and medications and supports and physiotherapy, but still community grassroots based. So that's kind of what they know as the community health movement, community mental health movement. That's how the chapter opens. And then it introduces you to psychotherapy and then psychoanalysis. So psychotherapy, which you'll find on page 334 and 335, is basically just the systematic way that clients and therapists interact in sessions, therapy sessions, and they work on a variety of behaviors and thinking processes, cognitions. So they work on a variety of helping patients gain self-awareness, learn about how they think and how they behave in order to find more constructive and adaptive ways of thinking and behaving, helping patients work through their thought processes and come up with more logical or healthy processes, helping them to adjust and adapt and build overall personal sort of growth and development. So all of that is really what's known as psychotherapy, working on the psychology of the mind. And then psychoanalysis, which you've heard before, was really a Freudian concept, good old Sigmund Freud, and still has roots in a lot of traditional therapies. If you look at, the classic model of psychoanalysis is the couch with the patient, the client, and then the armchair psychologist asking the patient to explore their behaviors and their actions and their thoughts, to sort of be introspective and insightful about their behaviors. That's kind of traditional psychoanalysis, and that information is on page 337. Freud believed that this was and many psychologists do, that this was a very cathartic process, that by speaking about your experiences and your emotions and how you cope and deal with the world, that would be, have therapeutic benefit and be cathartic in terms of releasing emotional tension and emotional stress and bringing that all to the forefront in order to improve your well-being. And then, of course, the therapist would work through a variety of techniques to help you. One of the techniques Freud did was dream analysis. Julie wrote her paper about that, as well as hypnosis. And psychologists today still do a lot of that sort of interpersonal, therapeutic kind of relationship. Moving through the chapter, I'm just kind of going over everything in a bit of a high level. On page 339, you get introduced to a concept called client-centered therapy. And that is exactly what it sounds like. It's putting the client at the heart of the process. It's following their lead, providing treatment that is very respectful, a real humanitarian humanitarian sort of perspective, human first, right? Working with the whole client. I used to work in an agency and we called it family-centered practice. Same idea, the family is at the heart of decision-making, the client is at the heart of decision-making. It is a very respectful process, it's warm and inviting and, kindness, so that clients can feel like this is a safe space to be open and honest about how they feel, that there won't be judgment, and they sort of lead the conversation and lead the dialogue, and the clinician is usually more quiet, asks questions, guides the conversation, but really provides an empathetic listening ear and lets the client focus on what they need to talk about. I said humanitarian earlier, and I meant the word humanistic, similar definition. So that's what that one was about. The textbook gets into a lot of other types of methodologies and treatments. They talk about behavior, Gestalt therapy, systematic desensitization, which we have talked about before, where if there's fears and phobias and anxieties associated with certain objects, my fear of rats, that systematic exposure will eventually desensitize the fear, or at least that's the goal, right? That talking about, in my case, rats, having exposure to pictures of rats, eventually maybe watching videos, eventually having them maybe in my space, but in a safe way in a cage, and on it goes, to eventually try to help me understand that I can overcome that fear. It might not be rational. My beliefs about rats might not be accurate. If I was willing to go through a systematic desensitized program, which I'm not. So moving along, there's a lot of other types of therapies, which I will not get into. And the main reason why is because the most common and most effective treatment we tend to know about today are the CBD and the DBT therapies, which are towards the later part of your chapter, as well as drug therapies. And so I want to really put some emphasis on those. There is some good information about operant conditioning procedures, page 344 and 345. And if you remember operant conditioning, the key thing there is rewards and consequences for behaviors, right? So it works really well with children if you're trying to extinguish negative behaviors. The way to do that is to have consequences for negative behaviors and rewards and positive things for the positive behaviors. We've talked about all that before. Keep going. We're getting into the cognitive therapies on page 346, and what makes a cognitive therapy so effective or beneficial is that it's about changing the way the patient thinks. And cognitive therapies, cognitive behavioral therapies, changing the way you think and behave, helping you think through doing things differently, trying things a different way, seeing if we can solve problems and discover solutions, is very positive and often quite successful in therapy. But it's important to note that it doesn't work for all mental illness. It can be particularly effective for, anxiety and more mild depression, some phobias, some things like that. Not so much with any of the really sort of psychotic behaviors that might be associated with schizophrenia. Talk therapy, cognitive therapy is not really going to, address delusions and hallucinations, not on its own. I'll talk more about that in a minute. So cognitive therapies. Can we encourage new thinking, new ideas, new thought processes to help you solve problems and help you to gain perspective so things aren't blown so much out of proportion? That really is what it's about in the role of the therapist, as well as adding the behavioral component where if I'm changing the way you think, I can then help you come up with new strategies for how to act and behave in situations. If you're dealing with anger or hostility or emotional regulation issues, a therapist can be really supportive in assisting you to come up with alternative ways of acting, thinking, and behaving. So cognitive behavioral therapy, top of page 349. This is the one that is recognized by the majority of psychologists and therapists today as sort of, number one in treatment and in effectiveness. There are many different types of cognitive behavioral therapy, and one of those types is what's known as dialectical behavior therapy. That was originally a therapy more specific to people with borderline personality disorder to help them be more mindful and thinking in the moment, trying to learn how to control their emotions and regulate better. Learning new skills so they could have a better tolerance and not react with anger and hostility. So it's a form of CBT, but it's got its own unique perspective in that it's more about mindfulness and emotional regulation and learning new skills. CBT really helps in a lot of different mental illnesses, helping you address irrational beliefs, how to change those irrational beliefs, how to not catastrophize, how to cope with stress, how to work through problems in a more constructive, proactive, and healthy way. The goal is for you to work on a specific problem in increments. So CBT is often short term with a real goal orientation that we're working on a specific problem. And the therapist will monitor and track how the patient is doing, what's working, what needs changing. Often the therapist will encourage the client to journal and so like in between sessions to kind of help the therapist understand the process of thinking in between the time they see the patient between sessions. So monitoring, evaluating, challenging in the session, challenging the client to say, why is that your choice? Why was that your reaction? Help me understand kind of what your thought process was when you made that choice or acted in that way. What might have been an alternative strategy that could have been more effective. And oftentimes when the client will say, I don't know, a clinician may say, well, what would be your best guess? Or what might be a possible answer to that? If you aren't sure, could you hypothesize or guess? So that basically is the gist of the CBT and the DBT. The textbook quotes that 4 out of 5, I think was the number of psychologists in Canada, prefer these methods over a lot of the other methods. But certainly having a variety of tools in your toolbox, different strategies, different approaches, all done in the form of a talk therapy with a client-centered focus is the point. So I'm going to wrap up this video and launch the next one, and then we'll be done this chapter. So I will finish chapter 14 talking about how CBT is validated, also talking about clinical interviews and clinical assessments, and that will bring us to the end. Bye for now.